we celebrated the
16th birthday.
We celebrated the victory of India in the World Cup and Dhoni's 6 in 2011. We were doing a course, certified course in evidence-based diabetes mellitus together, along with our president Dr. P.K. Gupta sir and patron Dr. P.K. Mathur sir, Dr. S.K. Mathur sir. So our association goes a long way. I see in him not a budding endocrinologist, but an endocrinologist who has arrived. He has his own practice. He has his own practice in Green Park. And कमाल की बात ये है बॉस कि एक दुकान पहले एवरग्रीन की स्वीट शॉप है और नेक्स्ट शॉप जो है वो डायबिटोलॉजिस्ट की है. कमाल मतलब just see the planning. I would request Dr. Manish to felicitate our two speakers with a cup from PFI, Dr. Monashis Sahu. Dr. Samir Mehrotra. We have this wonderful directory which Dr. Sushruta Almas worked so hard to produce, to reproduce, and many of you gave advertisements and gave money to support PFI. I would request Dr. Manish to give it to Dr. Monashis Sahu. It has all the members of Physician Forum of India as members. There are hands-on articles on various issues, whether it is asthma, whether it is diabetes, whether it is red eye, so many things, and it is absolutely the who is who of Physician Forum of India. Over to Dr. Manish.
Thank you, Chief, for a long introduction, and I'm privileged for this role which I've been given tonight. I'm humbled by this. I must stand corrected. I'm not an endocrinologist. I'm a DME in family medicine who does diabetology as well. My training extensive during my MD time was under an endocrinologist, so therefore my experience in endocrinology grows, but I'm humbled by that. Thank you, Chief. So let me welcome tonight's speakers, Dr. Monashis Sahu and Dr. Samir Mehrotra. But before we start the story of what we're going to talk tonight about, glifosins, starts long way back. I don't know how many of you know when was the first time it was discovered. Does anyone know here? Sir, Dr. Tulsi sir? First time when was glifosins discovered?
I won't remember.
Sir, 1835. 1835 or 1850s. First time we knew of this chemical compound called flivorogens, right? And from there it was an intestine. I had to open Wikipedia as well, right? But at the same time, it's an interesting history. It took almost so many years to come into clinical practice, and in 1950s the first clinical trial was done, where they found that there is some molecule where we can come to only a kidney-specific blockage of the SGLT2s. And then 2013, 2014, DAPA, CANA, EMPA came into the picture. But the story started way back in 1950s. So imagine, and sir, discovered from which natural product? Not from the audience, not from the speakers. Anybody from the audience?
पेड़ की छाल में से निकला था.
सेब की पेड़, apple tree part. So that's where it goes, right? So it's very interesting. So let me not take much of the stage time anymore. Let me welcome Dr. Monashis Sahu. He's a consultant endocrinologist at Women's at many places. He's been a friend and mentor to me in many ways. We have discussed many difficult cases. I said all my tough cases to him, by the way. I said, if you don't want to take insulin, that's the next guy you want to go talk to, right? He's got many important memberships. He's done his MD, DM. I can't talk much, sir, but I'm humbled to, welcome you. Dr. Sahu. This small change, Dr. Samir wants to quizzes at the end of the lecture with his ECGs, so therefore he is kept it there.
Thank you, Dr. Manish. Always inspired by Dr. Chauhan's way of initiating the things, and I'm exceptionally surprised that this is 776. So me and Samir were calculating कि कितने साल से about a consistent effort. So it's almost like 15 साल, more than that. So many more life and years to BFI, and equally speaking, I'm a bit emotional because yes, that was a tough year last year for me. And I know Dr. Chauhan that personally you also were taking care of trying to get all the updates. So a lot of friends from both medical as well as the pharmaceutical world always said, okay, Dr. Chauhan आपका updates काफी लेते थे. So thanks at least for trying to find out as to what's happening to fellow physicians from the community. So I'm very, very grateful to you, sir. Dr. Manish, while you send some tough cases, but the fact is कि वो cases का already इतना workup हो चुका होता है. And plus he has already set out all the algorithm. तो कई बार मैं बोलता हूँ आप आए क्यों हो? Whatever you said it is right. Now you can please tell me you want to take an insulin or don't you want to take an insulin? और algorithm वहाँ से फिर start करते हैं. So quite often they actually then therefore get back to you. The third, in terms of, although it happened by default, that Dr. Samir's presentation was before me, the cardiologist. But isn't it so true that when the endocrinologists fail, and or for that matter, let me not use this word, the fact is that taking care of diabetes is no more and should not be just under the domain of only the endocrinologist. We all understand that the prevalence is increasing by leaps and bounds. So everyone should know about diabetes care. It's something like about infectious diseases also. So there was once upon a time trying to groom up that speciality of infectious diseases. And I still remember one of my mentors stating that everybody should know how to treat through the infectious diseases. I think the same holds true for diabetes as well. So when we don't take care of diabetes, so पहले diabetes का care आएगा. If you don't take care of the diabetes, then obviously you'll be needing other specialists like nephrologists and the cardiologist. So I think although it happened by default, Dr. Manish, but it certainly is so true philosophically that the ultimate goal for treating diabetes therefore is to prevent the complications, so that we don't need the interventions from the cardiologist perspective, though I do understand that everything lands up with its intervention. Coming back to the so-called apple, yes, it is correct. It's sourced from the bark of an apple tree, and we have been pumped in with this kind of an information. And understanding about so many benefits of medications, of SGLT2 inhibitors especially, which has led to an absolute proof that yes, it reduces hospitalization due to heart failure. Yes, it also impacts upon the cardiovascular death. And yes, it also impacts in further deterioration of the renovasculature aspects and therefore a reduction of CKD events. And perhaps for that matter, it certainly justifies the famous statement that an apple a day keeps a doctor away. Perhaps it was something about that apple. But since you started with this quiz format, so let me also say a kind of a question and then an answer that I will give. An apple a day keeps a doctor away is not the first proverb about that apple. The original proverb goes like this: if you eat an apple before going to the bed, you will keep the doctor away from earning his bread. So that was the statement from the initial proverbial stuff from Wales, which then got converted to an apple a day keeps a doctor away. So actually it was like eating an apple.
If your wife is a doctor, then
If your wife is a doctor,
you eat an apple.
yeah, that's why doctors should not eat the apple. I mean, thanks so much. I'm certainly enjoying this. Okay, just to do the honors to the slides, it's already 9:30, so I hope to be short enough out here. The topic out here is the legacy, and it's a very apt topic. That's an acronym which, if expanded, it's like linagliptin plus empagliflozin for, every word is important, that just justifies the entire slide deck. For the glucometabolic benefits. That means that medications such as empagliflozin is not just a glucose lowering therapy. We are talking about the metabolic benefits. So gone are the days when we are taking care of the केवल glucose manage करना है. We have to talk about what is a therapy which has got the benefit of beyond the glucose, such as let's talk about reduction of weight. Forget weight for a moment, even for the kind of our own setup of a normal BMI as well. There's the central adiposity. So anything that can even take care of the central adiposity, reduction of the overall fat, and even in terms of the metabolic, let's not forget the component of uric acid. So although it is a surrogate marker, anything that can impact on the uric acid, all the various parameters of metabolic syndrome, anything that can impact upon the blood pressure, and anything that can impact upon the lipids. Now, we don't have a drug which can impact on each and every parameters. Like if you go back to the journeys of SGLT2 inhibitors, जब शुरू में आया था, there was a bit skepticism because A, it is removing glucose by urine, so we were thinking that urine infection बहुत ज़्यादा ना हो. But then even the renal glycosuria, the so-called renal glycosuria, which is a kind of a genetic diseases, so उसमें भी there was not an increased prevalence of urine infection, so that gave us the confidence. Second, there was a lot of hue and cry about the fact because on the usage of SGLT2 inhibitors, actually the LDL cholesterol, we saw that the initial data, there was a slight elevation. But isn't it so beautiful now to stand and say that, you see, there are now data to prove that once empagliflozin is used, it reduces CV death, it reduces the cardiovascular implication. So maybe because there's a reduction of weight, maybe because there's a reduction of blood pressure, even if there's a few notches of an LDL elevation, that's already balanced. And we are also living in an era where there's a lot of debate about the LDL cholesterol and the HDL cholesterol as well. That is it really a bad cholesterol, etc. And then when you read about, it's also about taking care of the two drug agent like linagliptin plus and empagliflozin. Can it also impact upon, the word is cardio-renal risk reduction. So there's an impact, a positive impact on the cardiovascular. We are all have been pumped in with the data. I don't think that I'll be again repeating all those data points out here. But also equally important, we must emphasize that also reduces the renal risk. So there's the renal risk reduction. And वो जो मुन्ना भाई MBBS का एक dialogue था where Boman Irani said, don't get emotional with patients when he said that otherwise you will not be able to practice. But I think diabetes care demands a lot of emotion, and perhaps for that matter nowadays everything is so personalized. We are living in the era of personalized medications. So sometimes I believe in the adage that treat your diabetes patients as if you're treating your family members. Otherwise it is a silent disease. कुछ पता भी नहीं चलता. There's nothing in the diabetes. What's there in the diabetes? So quite often what I tell my patients is that you see, glucose is just at the wrong place. And that is it is inside that vascular pipe. That's not the place of glucose. The place of glucose is to move out of that vascular pipe and get into the brain, heart, lung, muscles, kidneys. It doesn't move out. So brain में क्या होगा? Mood swings. Doesn't get into the muscle, the muscular fatigue and the cramps. It then also impacts on the. So this is what the colloquial aspects of explaining to our patient, but it's equally important to reflect back that it is also scientifically important, and that's the reason why we talk about microvascular complications and macrovascular complications. In other words, diabetes is a vascular disorder. So whatever medication it is there, and as if we are treating our family members and friends, we need to treat not just the glucose. We need to impact upon the so-called vascular poison which is irritating the vascular tree the moment the glycemic load is high. Do something so that the insult on the vascular aspect is reduced. Whether scientifically we talk about inflammation reduction, you talk about anti-inflammatory properties of the medication, but what does SGLT2 inhibitors principally do? They remove that glucose burden from the vascular pipe and throws it out from the entire excretory system, the nephrourinary excretory system. So the whole aspect is linagliptin plus empagliflozin. Does it really help our patients? Empagliflozin certainly yes. Linagliptin also certainly yes. And not only is there metabolic benefits, there's also cardio-renal risk reduction. So I'm quickly now scrolling through all the slides. Next 10 minutes, and I must be stopped after 10 minutes. So this was a study which actually helps us understand why do we need to treat our patients. This is an observational study, very simple. The patients there, they were on one medications and they just tried to observe what do we do, observational data. And they divided into two categories. Number one, whose HB, so the drug 1 se lekar ke drug 2, there was an arm which was intensified the moment HbA1c was also less than 7.5%. And the other arm, which I, along with many others, also keep on cajoling our patients, and we also say कि हाँ ठीक है थोड़ा सा और देख लेते हैं, and we finally reach to a point where the HbA1c is really very high. That means the HbA1c is more than 7.5%. In other words, the arm is an early intensification and a late intensification. So the question is there a benefit of it? So what about an early intensification? Means that even if the HbA1c is 7.1%, please talk with our patients and think about if medications can be intensified. So is it really beneficial or not? And this is number one. What it shows is that if you do an early intensification, over the next 3 years, the HbA1c is better. If you do a late intensification, the next 3 years, even if you're putting like 2 drugs or 3 drugs, the HbA1c is not better. And this was a global study. There are like famous authors from Kunti et al. Also who participated in this. And a very elegant paper, simple study, but a very important information is that if you intensify early, the next 3 years would be a smooth journey. Just the first intensification if it is done early. Proportion of patients who attain a less than 7% is also very, very beneficial. So the take-home message out here being, there's a lot of importance of an early intensification, maybe because perhaps what is called as a vascular memory, metabolic memory, glycemic memory, and these are like terms which I think it's a mixture of English literature as well as the medical issues. The whole idea is that कि शरीर को अच्छा लगता है अगर sugars जल्दी better हो जाए and it will behave properly. It's something like if the car is serviced at periodic interval and early, the engine will be better. I was talking here about cars a few minutes back. So those were the key takeaways from the so-called Discover study. Global trial, global observational study. Early intensification करने में क्या फायदा है? Late intensification, what is the benefit? The benefit is that if you do an early intensification, the next 3 years is also well taken care of without the need of further intensification. You do a late intensification, you'll need repeated intensification again and again. So what are the factors that are associated? Why are we not able to take care of our diabetes population with a better HbA1c? I personally feel that we of course forget the counseling part, which is not so well with most of our patients. We are hardly taking care of just 15 minutes with our patients, which is actually very suboptimal. But by and large, the younger age, the higher BMI, the high carbohydrate intake, and the higher HbA1c that all of us are beginning with in setting of diabetes. Quickly about a patient profile, 49 years. He is diabetic for the past 2 years, blood pressure is really okay. BMI of 28, that's obese. The patient is on metformin 500 twice in a day. And the HbA1c was 8.3% around 6 months back. Currently on metformin 2 grams maximum. And we find the current laboratory 8.6. So the crux story is that obese patient, or at least from the picture cartoon, there's a central adiposity without any doubt. The HbA1c is high and is on metformin 2 grams per day. The question, again, let's jump the boat with context that we are here, and thanks for BI also for setting up the stage. Whether you use one drug therapy like just a DPP4 inhibitor or an SGLT2 inhibitor, or would you like to go for straight away a kind of a combination therapy which is empagliflozin and linagliptin? So I'm jumping the question out here. How many of you would choose at an HbA1c of 8.6%? Just raise your hands. Only one drug therapy after this, like linagliptin or just an SGLT2 inhibitors. How many of you would use a dual therapy combination? So it's quite often. So I can step back. Job is done. I mean, sorry. So the question is, it's always good to reflect as to why we do and what we do. So what we do is that yes, the fundamental ground out here is that if we say that we need for this 49 years gentleman who is a diabetic for the past 2 years, sugar jitna control kar sakte utna badhiya. I mean, try to target even for an HbA1c of 6.5, 6.8% also. Not this modest of 7%. Had this been someone who is 79 years, I would not have spoken like this. I would have said, ठीक है, all I am targeting is even an HbA1c of 7.5%. इसमें HbA1c अगर 6.5 जाना तो we are talking about almost like 2.1%. Even with the dual therapy, it needs a lot of push with the diet and lifestyle. With a single therapy, the HbA1c will be hardly reducing by 0.8%, so that is correct as to about the multiple raise of hands. So the question is, and that's what we have already stated, the question is why, what is the importance, and as I said that to treat a person with diabetes as if we are treating our family members or friends, we need to understand about the vascular impact. And number one, the agent should be powerful and early efficacy, proven with the combination of empagliflozin and linagliptin. Both the drug therapy have got a low risk of hypoglycemia. There's in fact no hypoglycemia that typically observed with my patients. There is certainly a weight and BP reduction without any doubt, and many of you would have even seen with this oral GLP-1, the weight lowering, the magnitude of the weight lowering. It is almost, which was also compared with empagliflozin, the Jardians. It was found to be the same. We are not talking about the injectable which is available at US. We are talking about the oral therapy. So that gives you that robust confidence about, yes, it also impacts on the metabolic implication. Now, the dual therapy, even if you have to talk about A, the science, we talked about the previous slide. B, if you talk about the pathophysiology, it impacts almost all the varieties of octet as we understand. So you have both a kind of a reasoning from a pathophysiological angle as well as a kind of other science in terms of from a pure mechanistic and mathematical aspect of HbA1c. So there's a poll in your reference case, which one would you prefer? Would you even prefer a sequential use or just a combination? How many of you would just try for a DPP4 inhibitor for 3 months and then go to SGLT2? Raise your hands. And how many of you would straight away go for just the dual combination? Almost everyone. I don't know why I'm here. Thank you. So as a next line therapy, it is correct. There's compelling reasons. I think I'm just going to quickly brush through the slides. The efficacy is that, and this is again important to understand, the HbA1c is very high. That's where the SGLT2 really throws out that glucose with the glucosuria. There is a robust HbA1c reduction. But Jesse HbA1c touches to around 7.5 or so. The DPP4 inhibitors also beautifully take care of it because it's well known that it reduces the glucagon. 2 minutes more. It reduces the glucagon and improves upon the insulin. It takes care of the postprandial meal coverage. And that's principally what was found in the trials, in which it was found that usage of the therapy, combination therapy, was much better with comparison to HbA1c, whether it was sequentially or whether it was an independent singular therapy. So that's important. The question here is that the mathematics we have again discussed, and it's again a common sense. दो drug को इकट्ठे मिला करके देंगे, it will be better than the sequential for sure. It will reach to an early efficacy. This also helps us understand why do we need to use it, because the first 3 slides talked about what's the benefit of early intensification. You intensify early, the next 3 years would be a smooth journey, and it has been proven by this global trial of a Discover study. Body weight, blood pressure reduction, serum uric acid, don't forget about it. It also is true that with serum uric acid, both linagliptin as well as empagliflozin has been found to reduce the uric acid, again an integral component of metabolic aspects. So the side effects is also very, very minimal, as we have understood. Even the genital tract infection with the dual combination is lesser. The hypothesis, as you know, DPP4 inhibitors in fungus, that's blocked, so the replication of fungi is at a very lower pedestal. The question is, we all understand about the science, is this enough? Because quite often we are talking about the cost of a therapy also. We are talking about close to around something around 1600 rupees per month or 1700 rupees per month. And that becomes like, why? So we need to understand this, that we are talking about protection, we don't talk about so much of pharmacoeconomics or health economics. But I think the time is enough. And nowadays I have seen that patients are understanding, because they're understanding it's very important to prevent a complication rather than spend so much of dollars in the complication. And if you can just put that into the context, the submission to most of my patients when we go on to this premium therapy is like this, that even if you are spending close to around 20,000 rupees on one drug therapy per year, something which has been proven to reduce a cardiovascular, and just look around is 20,000 rupees into 12 years, and we do this for at least someone who is 55 years or even into 20 years. You calculate the money. Vis-a-vis, if you land into some complication, वो उतना ही पैसा एक admission में निकल ही जाता. So when you talk about this from this perspective, that's when it dawns with the patient that yes, it is important, because it's our responsibility to convince the patient as to why that therapy is needed. This is the last slide, as I would just put it out here, is that the potency of a pill with this IC50, inhibition concentration 50, is also determined by the size. And it is such a potent concentration, मतलब इतना इसका IC50 दमदार है, that the size of the pill, both the SGLT2 and the DPP4 inhibitor, is very, very small. This was talked from my side and gone into feedback to the company long back. So the size of the pill was exceptionally important from a pure pharmacokinetic and the pharmacology perspective. So I've got everything in this pill, and thank you very much. Back to the
Manish.
Down here.
Thank you for the amazing talk, sir. And I think the size does matter, though.
Okay, size
small.
matters.
All right, so we go on to the next talk. Help me with the slides, please. All right, so sir is saying, what's the need? But there is, we need to, follow the protocol. So let me introduce Dr. Samir Mehrotra, whom we have heard him before. I have referred a few of my cardiology questionable cases to him, and Gyan Mila usse we have learned, I have learned at least. So he's a highly dynamic, highly skilled interventional cardiologist. As sir said, we should not identify any person with his skill set because they do everything. They have been trained. We all have been trained. He's MBBS, MD, DM, right? Presently he's at BLK Max, and he's done a lot of wonderful visits at and associated with various hospitals, PSRI, Primus, Max Shalimar, JP Noida. He's a member of Cardiovascular Society of India, and his areas of, I think, interest are quite long, so I won't get into that. But sir, welcome again for your talk. Looking forward to your talk.
Thank you, sir.
And if I may just add on, he's my batchmate. And even before this entering into this cardiology, he was one of the best person to do a kind of a CSF. So his skill set was very, very good, even drawing the spinal fluid. So, so the fact is that I have no questions about the skill related perspective. Thank you.
So practically, I don't know whether I should call it Dr. Monashis or Monashis. That's the So he has made my job quite easy. Actually, that was the reason I told him to give him the first talk so that he can set the stage, and then I can just show a few slides and then I can get away with it. So where's your presentation? So I told you, where's your presentation? So practically they wanted to talk, they wanted me to talk about the role of SGLT2 inhibitors in heart failure. To be very honest, diabetes and cardiovascular diseases are as close as me and Dr. Monashis Sahu. In fact, diabetes was supposed to be a cardiovascular equivalent in the previous days, and even now it is considered as a cardiovascular risk equivalent. The reason is that anybody who has diabetes has a very high probability of developing a cardiovascular disease. And many patients who are having a cardiovascular disease over a period of 5 years, basically because of the lifestyle, they usually, or because of some drugs like beta blockers, they usually land up with diabetes. So they are as closely related as possible. So it doesn't come as a surprise that after so many years you get a drug which was initially started for the diabetic patients and which has landed in our lab, to be very honest. The diabetologist started doing all the trials and we took the credit for SGLT2 inhibitors because we started treating patients with heart failure. Yeah, sure. So why is it that the drug is beneficial in heart failure? If you look at the pathophysiology of the drug, or the heart failure rather, activation of sympathetic nervous system, we are giving beta blockers. Activation of renin-angiotensin-aldosterone system, we started with ACE inhibitors, we went to ARBs, and then what happened, they said we want to inhibit the natriuretic peptide levels also. So they came with a combination of natriuretic peptide and this renin-angiotensin. So what came was ARNI. Valsartan, ARNI, angiotensin receptor blocker plus sequepectin. And then we landed up with another drug. So the beautiful part of the drug is that it leads to immediate symptomatic improvement in your patients with heart failure. Why? The drug is causing glycosuria. It increases the excretion of glucose in the urine. because the glucose is excreted. So definitely sodium will also be excreted, fluid will also be excreted. As a result of which, you are hitting 3 points. Glucose, lowering the blood sugar levels.
Not ready.
You want me to forward the slide? Just a minute. ऐसे ही बोल देता हूँ. So these are the slides. Yeah, these are the slides. So you can forward it. So practically, we are hitting at the sugar levels by causing glucose excretion in the urine. We are decreasing the sodium levels in the body, and we are decreasing the free water also. As a result of which, the fluid overload is prevented, and that is why you get all these benefits you see in your patients who are with heart failure because of SGLT2. You are reducing the fluid overload, so patient becomes symptomatically better. All these trials show your NT-proBNP level improves, patient becomes much fitter. But besides that, they are also having other impact. The most important is they produce a change in the metabolism of the heart. Normally we say that glucose is not good for the heart. So what they do, they change the metabolism of the heart from glucose to that of ketones. That is something which is very important. And the third thing which they do is that they decrease the epicardial fat. Now why is it important? The epicardial fat leads to inflammation. You all know the coronary vessels are epicardially located. So if you reduce the epicardial fat, you reduce the inflammation and you reduce the chances of atherosclerosis and cardiac events. These are the various other effects which you are getting with SGLT2 inhibitors. As a result of which, SGLT2 inhibitors have now established themselves as one of the pivotal drugs in the treatment of heart failure. As of now, what people say, even in the latest heart failure guidelines of 2022, so what they say is that when you start a patient, treating a patient with heart failure, you start with beta blocker, that's the cornerstone, there's no doubt about it. Normally, we as cardiologists used to start ACE inhibitor or ARB, then we went for ARNI. Now they said shift to SGLT2 inhibitors. So the drug of second choice, or rather simultaneously you have to start your patients on beta blockers with SGLT2 inhibitors. I find this drug very beneficial in patients with heart failure. The reason is because I am quite reassured that this drug is not going to cause hyperkalemia in my patients. The second thing is that I am not worried about the renal function. I know the SGLT2 inhibitors are going to be safe even at a GFR of around 30. I am right, Dr. Monashis? So we can safely give these drugs in patients who have an eGFR of around 30. While if I start my patient on an ARNI, I know I have to worry about the potassium, his creatinine might start rising, and then I will be bothered about it, how to manage that rising creatinine, then I will start the ARNI. And the biggest problem is that ARNI in the Indian setup, when you start, the minimum smallest dose is 50 milligram tablet. In the Indian setup, patients many times don't tolerate the 50 milligram tablet twice a day. Sometimes you have to start it 50 milligram half tablet twice a day. Now ARNI as such a tablet has valsartan plus sacubitril. When you break it into half, 25 milligram, you don't know how much valsartan is being given to your patient, how much sacubitril is being given to patient. It's not a score tablet. So that is where the problem comes. When you look at all these practical aspects, and it has to be given twice a day. Another important thing is that if your patient misses ARNI because of the cost impact, then sometimes your patients can present with rebound heart failure. That is something which is very difficult to manage at times, although the incidence is not that high. But when we see such patients who stopped ARNI, went into heart failure, then it becomes quite difficult. So considering all these points, it is always better to say that when you want to start your patient, treating your patient with heart failure, I think SGLT2 inhibitors become the drug of first choice. Once a day regimen, hyperkalemia is not there, and along with it, sure. So I think I have explained most of the things, contextualizing the risk among patients with heart failure. So this shows that risk stratification is very important. When you see a patient with coronary artery disease, you have to estimate what is the 10-year risk of your patient of developing a cardiac event, whether it's 1%, 1 to 5%, 5 to 10%, 10 to 20%, or more than 20%. You stratify your treatment according to that. And patients who are very high risk or extremely high risk, These patients have recent heart failure hospitalization, worsening heart failure with an EF of around 40% or heart failure, advanced heart failure patients. So these are the advanced heart failure patients in our case. Now this is very important. Each event of hospitalization for heart failure leads to progressive deterioration of clinical status. And this is in fact true. If your patient with heart failure starts getting admissions every 3 to 6 months, then you can prognosticate the family that he won't survive for more than 2 years. Whatever said and done, tell the patient or family to compete with each other, and you know that they are not going to survive for more than 2 years, whatever you do. So our aim in the treatment is to decrease this rapid decline in hospitalization. It's like when you cardiovert a patient, every time you cardiovert a patient with LV dysfunction and VT, you depress the ejection fraction by 1 to 2%. So always remember this thing, you have to treat that rather than cardioverting your patient. It's the same way. Every hospitalization reduces the risk of fail. Now this was a CSI Kerala acute heart failure registry. Something very important. The key findings of the study was that you know the triple therapy, you know the guideline directed medical therapy, but hardly 20 to 30% of the patients were being given the proper treatment. What happens? A patient gets admitted to you with heart failure. We manage the patient with diuretics, iron drops to stabilize the patient. We are worried about the creatinine. So we are hesitant in starting ARNI, ACE inhibitor. We start with low doses of beta blockers. So when the patient is discharged, many times the patient is only on beta blockers. Sometimes people start giving them the digoxin. Digoxin is a very good drug. In fact, it's a very good drug, underutilized because it's very cheap drug. So no company is ready to do a trial on digoxin. That's the reality, but otherwise it's a very good drug with a narrow therapeutic mark. So the most important thing which I want to highlight is not even 30% of the patients have been on guideline directed medical therapy. That is the reason why these patients start coming back to you again and again with heart failure. Now coming on to SGLT2 inhibition pathophysiology, I think I have already explained most of these things. Preload reduction, afterload reduction, and effects on myocardium. I think this is something which is very important, we should focus. This effects on myocardium and decreased epicardial fat and glucose utilization, all these things lead to decrease in the inflammation. And you all know atherosclerosis is a chronic inflammatory disease. That's why nowadays they are saying that SGLT2 inhibitors are not only beneficial in patients with heart failure, they are also beneficial in patients who are having atherosclerotic cardiovascular disease. Sometimes people ask, why should we give them to patients who have a normal ejection fraction? So that is the reason. The trials are on the way. We will have our answers. Empagliflozin reduces the risk of death due to heart failure related events. EMPA-REG outcome, we all know that. Why did it reduce it? Because it reduced heart failure. It reduced heart failure, prevented cardiogenic shock, prevented sudden cardiac arrest, ventricular arrhythmias. That's why all the benefit was seen in these patients. Emperor reduced the study. It was also a phase 3 randomized double-blind controlled trial, which went on to see the efficacy of empagliflozin in patients with heart failure with eGFR more than 20. So even up till GFR of around 20-25, it is a safe drug. That is something which I would like to highlight. Confirmatory endpoints for primary outcome was cardiovascular death or heart failure. Key secondary outcomes were total heart failure and slowing of renal function decline. So the beauty of this drug is decrease the heart failure hospitalizations, decrease the recurrent heart failure declines, and decrease the rate of reduction of eGFR, the rate of reduction of GFR. So beneficial from multiple aspects. I think this is something which is self-evident. The moment you start giving your patients SGLT2 inhibitors, the graft starts separating. The reason being, it increases the free water clearance. Within 48 hours, you will start seeing the difference. And that is why these patients start benefiting. The earlier, the better. The earlier you start patient, the earlier they become less symptomatic and the earlier are the chances of the recovery. It consistently benefits patient groups with reduced ejection fraction. All these things are known. It is the effects of the drugs are not related to the age of the patient or the status of the patient, whether he is a diabetic or a non-diabetic, and or baseline use of ARNI or MRA. You can keep on giving your patient these drugs, plus you can add on these SGLT2 inhibitors to your patients. It does not worsen the overall safety outcomes in patients with heart failure with reduced ejection fraction. Hypoglycemia, we know it doesn't happen. One important thing which I think Dr. Monashis must be knowing very well. In your patients who are on SGLT2 inhibitors, if they come to the emergency in a stuporous state, always rule out hepatic ketoacidosis. And your urine will never show ketone positivity. So that is one thing I try to tell my colleagues and juniors, that if you get a patient who is on SGLT2 and he is stuporous, you find something is missing, always check the ketones in the blood, not in the urine. That is something which is missed many times. So the study design, I am not going to go into the detail of the study design. Most important thing, it's a class effect. SGLT2 inhibitors is a class effect. Any drug with SGLT2 inhibitor is going to benefit. Empagliflozin has the maximum and the most robust data. That is something which is very important. I think I have told all these things. Hypoglycemia, we know. The SGLT2 inhibitors and DPP4 inhibitors don't cause hypoglycemia. Once the sugar level in the urine, they decrease, their efficacy also decreases. So that is something you need to remember. Consistent effect in heart failure is moderately reduced ejection fraction and preserved ejection fraction. So this is something which is important. EF more than 50%. Should you give SGLT2 inhibitors in your patients or not? Well, to be very honest, although the data suggests, but I will be quite skeptical. वो कहते हैं ना, मार्केट में नई गाड़ी आए तो खरीद के ट्राई नहीं करनी चाहिए. You should wait for some time before you have some robust data to expand your indications to even patients who are having normal LV function. Your patients who have been managed with normal drugs, just adding on another drug just on the basis of some hypothesis is not the right thing. So just wait for some time. I think they will have their data in another 1 to 2 years, and then we can safely add these drugs to even patients with normal ejection fraction. No, this in-hospital initiation of empagliflozin in stable patients post-acute heart failure. If I look at it over the last 2 years, what I have seen, everybody is trying that a patient who is admitted to you in the ICU, sir, please start ARNI, please start SGLT2 before the patient is being discharged from the hospital. Now there can be 2 reasons for this. One reason is increasing the compliance of your patient. If in discharge I write a medicine, then I know that in a follow-up I have to give that medicine to my patient. But if on discharge I forget the medicine, then at follow-up I might again forget the medicine. So one thing, it increases the compliance. Second thing, it helps you evaluate the response of your patient to that drug over the next 48 hours. Now, when should you start? You should start, patient is not on any anotropes, patient is not on any diuretics, and that's it. Stable patient. So this I am not going to. So I think I spoke about this. Systolic BP, no increase in diuretic dose, no vasodilators, no anotropes. Stable patient, start this. Initiation at hospital, 36% greater likelihood in clinical benefit. Adverse events are practically none, to be very honest. So now this is one of the second last or the last slides. A patient comes to you, start with all these guideline directed therapies, start with a beta blocker. Then you choose whether you want to start SGLT2 inhibitor or you want to start your patient on a ARNI, depending upon the patient profile. And then depending upon that, you can add a MRA and diuretics. Remember one thing, this SGLT2 inhibitors produce lot of diuresis, so you have to decrease the dose of diuretics. Otherwise, your patient will come with hyponatremia. So remember this thing, you have to decrease the dose of diuretics in your patients who start on SGLT2 inhibitors. Even in the latest guidelines, they have to become the drug of first choice, but level of evidence is only class 2A, even preserved ejection fraction as well as reduced ejection fraction. But class 1 in patients with heart failure with reduced ejection fraction. So this is the way you should go ahead, beta blocker plus SGLT2 inhibitors, then ARNI and then MRA. This is the sequence you should follow now. Single dose, once daily, no titration required. Summary, proven benefits, I have told you how it works. When to use, I have told you as soon as possible in your patients with heart failure. So basically this is a quick summary of what I wanted to talk about SGLT2 inhibitors. If the Physicians Forum allow me, after that I would like to show 1 or 2 interesting ECGs to show what we are doing actually.
Go ahead.
If it's okay with me.
Go ahead.
Slide ka. So practically I call myself an electrician and plumber of the heart. I clean the vessels and clean the circuits. That's all.
Very important job, sir.
Short circuit ho jaye to yes. So, something which might be interesting for you. Can anybody tell me what comes to your mind when you see this ECG? Suppose you see this ECG, this patients come to you. And
VTAC.
so how many are there for VTAC? Okay, fine. Can it be SVT?
With evidence.
Who said with evidence? Good, great. So practically, sir, the diagnosis of VTAC cannot be proven as wrong. But when you see this ECG, grossly three things are evident. One is, this patient has a broad QRS tachycardia, right? Second thing is, this patient has right bundle branch block. Third thing is, lead 1 is negative, AVF is positive, so it's a left axis deviation. So three things are there: broad QRS tachycardia, right bundle branch block, left axis deviation. Now this patient came to the emergency, somebody diagnosed and started the patient on Amatron. Young female, 30-year-old female. So when this patient came to us, we were also confused whether it's a ventricular tachycardia or it's anything else. This was the history. She was post-TOF repair, post-double wall replacement, and had a normal biventricular function. So then something clicked our mind. We said TOF repair, TOF patients can have right bundle branch block. So then we came back, we went to the diagnosis. Okay, what can be the possibility? It can be a ventricular tachycardia, as you rightly said. The second possibility can be supraventricular tachycardia with aberrancy. Supraventricular tachycardia can be even simple AV node reentrant tachycardia, or it can be a atrial tachycardia. How to differentiate? Patient was stable, walking, talking, taking Cotron, enjoying. So we gave her adenosine. The rate started slowing down. So this was the ECG once we slowed the rate. So the things became quite simple on this ECG. You can see the PVs. Baseline, there is right bundle branch block. So this is the ECG of atrial flutter. The patient is having atrial flutter, which correlates with a background of TOF repair and double wall replacement. The atria are scarred. So this is a case of...
you didn't talk about the TOF repair earlier. That's why we said VTAC.
No sir, you are absolutely right. I am not denying that. I am not denying
After
that.
TOF repair, yes, repair, yes.
So, but what happens is that when we see our medical officers in the emergency, they see this ECG, they are so inclined to give Amatron. People don't realize that Amatron is a very toxic drug. It usually lands up your patients in hypothyroidism. And we have lost one of the cardiologists because of Amatron-induced pulmonary toxicity also. You all must be aware of Dr. Rissam.
Yeah.
So definitely it's not a very safe drug. From an electrophysiologist perspective, we want to start it as late as possible unless and until we don't have any other option.
But Dr. Samir, that's on long term. See, if you give Amatron,
suppose this patient,
not an acute.
Absolutely sir, you are absolutely right. But the thing is that if this patient was continued on Amatron, nobody would have seen it.
You never talked about the TOF repair.
I agree with you sir, I wanted to highlight that ECG actually. So this was it. So we have been planning for ablation of this patient. Now this was another child, an 11-year-old child. He was having recurrent...
Just a minute. So no harm in giving adenosine, see, in patients who have this tachycardia?
At least if you are suspecting that your patient can have SVT with aberrancy, you should at least once
No harm in giving that.
Few cases you can have these patients going into ventricular fibrillation if these patients have accessory pathway.
Okay.
So you can have those things. When you're giving adenosine, you should have patches attached to your patient.
Considering the age, younger age probably points towards SVT.
The diagnosis, the baseline diagnosis points towards SVT.
Right.
So this was another 11-year-old male, recurrent tachycardia. He had a cardioversion also. He was not responsive to calcium channel blockers, beta blockers. He developed tachycardiomyopathy and his ejection fraction was 35%. This is the ECG. Can anybody tell me what's the ECG? How many of you think it can be VT or VT? Definitely no.
No.
It's a narrow QRS tachycardia. So you can't see the P waves, but you can see these pointed things on the peak of T waves. T waves are never pointed; they are usually rounded, right? So you can see these pointed things. So that gave us a suspicion of atrial tachycardia in a child, normal child. This was the ECG. We took the child to the lab, and it confirmed. This is the actually when we do electrophysiology study, we put catheters at various places in the heart. The right atrium, right ventricle, bundle of hairs, and this is what we saw. So what I said is the pointed P waves, when we saw in the intracardiac, this was atrial. So this confirmed our diagnosis of atrial tachycardia. This is a very beautiful picture actually, very colored picture, very beautiful picture. But you might be wondering what am I trying to show you. So this is known as 3D mapping. What we do is that we try to map the whole of the heart by a 3-dimensional mapping, and the colors are different depending upon from earliest to latest. It's Vibgyor, violet, indigo, blue, green, red. Okay? And the earliest site is the red site. We try to see what is the circuit. We try to map the circuit. And these are the various projections. This is the cut is the tricuspid valve. This is the SVC. This is the IVC. This is the tricuspid valve. At this point, we were getting a red spot, and we realized that this is atrial tachycardia arising from the right atrium. See, it's a beautiful picture. You can see this tachycardia arising from this point, and it is spreading towards whole of the heart, both tricuspid valve, SVC, RA. We started ablating here. Sit, gone. Tachycardia is gone. ECG, sinus rhythm. It has been 3 months. We repeated the echo. The child has become normal. The child is totally off drugs. Child is playing, having normal activities. We repeated we got a cardiac MRI also done. Somebody was suspecting non-compaction of LV. Everything has resolved, and he is living a normal life. That is why I say that at times EP is very rewarding. 3 days back, we ablated a 13-year-old child with fascicular VT. He was again started on amantadine 2 years back, and we saw, and then we thought we should go and ablate it. We ablated it, stopped all drugs, child is doing fine, and no recurrence. So these are the times when you feel quite satisfied, and it is quite rewarding that you do EP, especially in these kids. Otherwise, they keep on taking these toxic drugs for a lifetime, and with recurrences. The problem with SVTs is that it's not that the drugs suppress them totally. They keep on having recurrences. You talk to these patients, they will tell you, we are scared to go out alone. We are scared that we should travel or not. Why? Because धड़कन शुरू हो गई डॉक्टर साहब तो अस्पताल भागना पड़ेगा, वहां पे वो जगह कहीं होगी नहीं होगी, हम जा सकते नहीं जा सकते. These are real life fears, apprehensions. And if you can fix these patients by doing these simple procedures, I think you improve their quality of life significantly. Diabetes, cardiovascular diseases, stents, angioplasty, definitely they are chronic diseases. But these are things which you treat your patients once. You have lifetime rewards in your patients. So that's why I just wanted to show these 1 or 2 ECGs, just to bring to your notice what we are doing as electrophysiologists, rather the electricians I should say. Thank you. Thank you for your patience.
Can we have the lights, please? Thank you, sir, for introducing some cardiology to the interesting talks, and it makes us more wiser, physicians to kind of, refer that. To set the ball rolling, before I hand over to the audience, my quick question to my favorite endocrinologist, Dr. Monashis Sahu. He knows that it's coming. So you talked about the early intensification, and you showed that slide. My only question and my recent updates on that, or at least to my thinking, we understood even with COVID, right? We saw many new diabetics coming up just with COVID, and it was talked as beta cell transient itis or beta cellitis. There's a new thought that the beta cells don't die. It's probably the beta cell, we thought that they would die and they won't come back. So once the glucotoxicity is gone, your take on do the beta cells come back? Is a term for that? So early intensification would also make sense on that.
So, as I said, that I can only replicate what Dr. Manish will say, which happens in practice and so has happened in this forum. Number one, it is correct that yes, there is a term called as an insulinitis. As the better way as an analogy, if I may say so, is thyroid and thyroiditis. So, quite a substantial proportion of such patients of thyroiditis, they recover. Similarly, when we talk about insulitis, quite a substantial number of patients also recover. However, for some, any kind of an inflammation, just remember what also happens in thyroiditis. We have realized that even 30% always land into this permanent hypothyroidism. Perhaps we are also realizing that the moment there is an inflammation with the beta cells, the severest format of inflammation, as happens in the lungs, it's a virus, it can penetrate into anything. Like as an example, neurologist friends are looking at demyelination. Similarly, the pancreas as an insulin-producing organ, so that can also get affected. And we don't have the value substantial, but a reasonable number of patients are landing into this chronic aspects of type 2 diabetes. So that was part one. What was the other part?
That was kind of leading to that from that data, can we say if there's fire everywhere, the beta cells go to sleep and they kind of wake up later?
Also there is a concept called as an immortality of cells, and this immortality of beta cells is also something which is catching up. But by and large, I think when we talked about the glucotoxicity, in the presence of glucose, the glucose itself being a toxic substance, not just to the vascular wall as I was talking about, it can also be toxic to the functioning of any cells, and so does it include the own beta cells as well. The moment you remove the glucotoxicity, yes, there are beta cell functionality which also improves. So the whole idea is that perhaps there is a cellular functionality, and therefore the concept of perhaps the beta cells do not die. And maybe for that concept, maybe we can talk about our sages, Rishi, Munis, when they used to say that yes, we can reverse diabetes. You never know, maybe after 15 years we might be talking about some secret which is yet not understood. But perhaps there is something which can also get back the beta cells.
Get the beta cells back.
Thank you, that's an interesting question.
I will open the house for questions. Please take it forward. Let Dr. ask, then after you, sir.
Okay, Dr. Manish, thank you. And Dr. Samir and Dr. Monashis, what a wonderful talk. Okay, so to both of you, SGLT2 inhibitors are rewriting the rules in cardiology, nephrology and hepatology, and should be prescribed as early as possible in type 2 diabetes mellitus to prevent cardio-renal syndromes. What do you say, sir?
So if I may say so, sir, just like God is one, similarly I think SGLT2 inhibitors are making us realize that all specialties should be integrated into one. So yes, it has really taken care of not just the helping hand towards every one of us who is taking care of diabetes, is preventing the cardiovascular complications, is preventing the renovascular complications. So yes, apple a day, as I say.
So Dr. Samir, JAMA, January 5, 2022, published a meta-analysis of 10 major RCTs. 71,000 patients, large number, and concluded that SGLT2 inhibitors reduce CV and renal morbidity and mortality and all-cause mortality as well, with remarkable consistency across all age, race, ethnicity, but did not reduce acute MIs. So why would you think that occurred? Because the events occurred in 4.66% patients who took SGLT2 inhibitors and 4.7% who did not take SGLT2, who took placebos. So what do you think is the likely cause? Would you say probably SGLT2 inhibitors have no anti-anginal effects, have no vasodilatory effects, do not reduce myocardial oxygen demand, and do not prevent fibrosis? What do you say, sir?
So the most important thing is that we have to first jump to the mechanism of SGLT2.
Right.
I already talked about it. They decrease heart failure by decreasing the fluid overload and causing natriuresis. So the primary benefit in mortality is seen by decrease in heart failure events, by decrease in the rehospitalization rates, and by decrease in the mortality which is associated because of heart failure. Right? For any drug to decrease the incidence of coronary artery disease, myocardial infarction, you have to have a longer duration, where you have to see that the plaques are stabilized or not.
So this study was just for 2.3 years.
So that's not
enough time.
that's not sufficient.
Right.
Right. That's not sufficient time. You have to look over 5 to 10 years.
Absolutely.
To see. So that is the major thing. They are correlating. They are generating a hypothesis that because it decreases the epicardial fat, it might reduce the inflammation, which might lead to a reduction in the atherosclerosis. And that is the reason they are saying that it's going to reduce the cardiovascular events because of MI. But to be very honest with you, you should always remember it's a drug which is used for decreasing the sugar levels and decreasing the fluid overload. Don't think that SGLT2 inhibitors for now are going to decrease the events in CAD patients.
And also the ketone theory.
Yeah.
Okay, Dr. Samir, let us talk about the recently Heart Failure Association or the European Society of Cardiology. In their recently concluded session at Florence, Italy, talked about the 3 biomarkers. So, which would probably look into whether the SGLT2 inhibitors would work or not. Dr. Manashis, probably you would.
For the heart failure, I know only about 1 or 2 of the biomarkers. I didn't attend that course.
So let me tell you about the 3 biomarkers, Dr. Manish, probably you know. So high sensitive troponin T, cardiac troponin T, which replicates or reflects the myocardial injury, the soluble suppression or tumorigenesis 2, which reflects the acute kidney injury, and the insulin-like growth factor binding protein 7, which reflects the vascular dysfunction and the myocardial fibrosis. So they said that if the SGLT2 inhibitors showed 56% reduction of MACE, if you have increased biomarkers, 3 biomarkers, and if you do not have increased biomarkers of these, probably the effects are not so much seen with SGLT2 inhibitor. This is a recently concluded session in the European Cardiology Society.
Basically, from the cardiac viewpoint, I understand the troponin is showing a myocardial injury. So in the same way, the other markers must be showing injury to the pancreas and injury to the kidney. So you are looking at acute markers which are leading to acute injury. If you find a reduction in the marker, then you say, okay, these are beneficial. From a practical standpoint, where I look at it, I see my patient has heart failure, I see the anti-pro-BNP levels. I find if the anti-pro-BNP levels are decreased in my patient, I know that drug is going to benefit my patient. Not by the drug per se, but by the reduction in the heart failure incidence. I think regarding the kidney and the pancreas, things you will be wise.
Anyway, let me continue. So, these drugs may improve outcomes, see, in ways we do not know. So, we should not deprive the patients who do not have increased biomarkers the benefits of the SGLT2 inhibitors. What do you say, Monashis?
Without any doubt, sir. I mean, this is.
I disagree, Professor. I say do no harm.
Yeah,
First do no harm. These drugs may improve. When you say may, so then I would not like to start the drug to those patients. What is happening is that they have very clear-cut inclusion and exclusion criteria in the trial. We try to extrapolate those inclusion criteria to a generalized population. It's very simple. I'll give an example of these drug-eluting stents. When drug-eluting stents came, rather bioabsorbable stents came, everybody started using it right, left, center. And initially they were given for type A simple lesions because they were thicker stents. Now everybody started using it for bifurcations, CTOs, and then what they landed up with? Stenosis, aneurysms, everything came out. But it took 5 years for them to realize it and withdraw it from the market. How many patients were already given a dissolvable stent on the pretest stent to bhul jata?
Sir, sorry, on that front, would you like to give this drug in a, for example,
In a 80-year-old frail lady with a heart failure?
SGLT2 inhibitors.
Yes, same.
Yes.
See, it depends on what are the chances of the urinary tract infection in that lady. If I have a patient who is having BPH, who is having urinary retention, who has a chance of prostatitis, and then I'll be slightly skeptical in starting SGLT2 inhibitors. I think Dr. Monashis can...
there's the art of medicine. As an example, someone who is having too much of a gastric bloating and already a GERD, you try to also limit the metformin doses. Similarly, anybody with a history of recurrent GTI, you try to. But I still feel that the closest to this holy grail in terms of use of SGLT2 inhibitors in the arena of diabetes, it's impacting almost every organ that we need to worry about.
So let me conclude, Dr. Monashis. So would you say the SGLT2 inhibitor should be level 1 indications for all patients of diabetes, as we have RAS inhibitors in CKD and we have beta blockers and mineralocorticoid receptors in heart failure, unless and until it's contraindicated? Dr. Monashis.
The answer in one word is yes.
Thank you, sir.
In the latest guidelines, they have become a class 1 indication for patients with heart failure with reduced ejection fraction, as you rightly said.
Wonderful, sir.
Dr. Bala had one question.
Dr. Bala, you have a question, sir?
Yeah.
Go ahead.
You said radiotherapy. Radiotherapy is very good in obese hypertension, diabetics. But how about the lean diabetics?
So we need to understand.
It doesn't want to lose weight.
So I've come across again several patients who do complain across that कि सर जब से start किया I'm just losing the muscle mass. Yes, it is there. Having stated it, from a DEXA related analysis of whether there's a kind of a lean mass, lean fat which gets reduced also, or the overall fat. The fact is that it does not really truly impact upon the muscles. And number one. Number two is that there has been also enough of data also to suggest that in a normal BMI, it works as a good anti-hyperglycemic medication with almost the same cardiovascular benefit. Now the question is, what happens to a kind of a lean person with a BMI which is less than 18.5? So that is where the data is lacking. However, having stated it, we need to understand that this is a diabetes medication. It's a medication which actually reduces the glucose, number one. Number two, if you fundamentally understand, if we all of us fundamentally understand that diabetes is nothing but a glucose at the wrong place, which actually impacts upon the vascular, and we are talking about microvascular and macrovascular complication prevention. Hypothetically speaking also, and mechanistically speaking, there is still a role of SGLT2 inhibitors in the setting of lean type 2 diabetes mellitus. Lean type 2 diabetes mellitus. The only one thing when you should, everybody, all of us should be cautious about, that the so-called lean type 2 diabetes mellitus should not be the so-called LADA or something which is kind of going to be type 1.5 diabetes. Yes, or in insulinopenic patients. And that can be easily understood by just getting a very simple urinary ketones before even initiating SGLT2 inhibitors. So the short abridged answer is, this can also be used in the setting of a lean type 2 diabetes mellitus without any concerns of further weight loss. So the more the weight loss, lesser the weight, marginal weight loss.
Dr. Monashis and Dr. Samir, I think you have done a wonderful job of elucidating the wonderful mechanisms of benefit on the heart and the metabolism of this empagliflozin and DPP4 combination. But I have some questions, and I think it will benefit everyone if they have 5 minutes to listen to this. I heard a talk by Dr. Adil Mehta from Cleveland Clinic in 2018 advanced diabetes course organized by Dr. Bridge. And he said, Dr. Adil Mehta said that I think that the SGLT2 inhibitors are an expensive diuretic. They are just expensive diuretics. And sir, you explained and Dr. Samir explained that SGLT2 inhibition works basically by excreting excess glucose from the place where they should not be to the place where they are destined to be, and sodium excretion If diuresis was the basic issue, none of the trials on diuretics ever has shown any mortality benefits. Agreed, sir?
Heart failure, yes. For heart failure, yes.
Never any mortality benefits by diuretics. We have an eminent endocrinologist and an eminent cardiologist here, and none of the trials on diuretics have ever shown any mortality benefits. Sir, it seems that diuresis probably is not the factor which is driving the mortality benefits, and the mortality benefits are not small. 38% relative risk reduction in cardiovascular mortality, morbidity, 32% overall reduction in mortality. Never in the case of any anti-diabetic drug in the history we have had such impressive benefits. I would like a comment from you, Dr. Monashis.
So the one thing is that this is certainly not a diuresis, not an ordinary diuretic, and the mechanism of action, if I remember it correctly, there was that if I got on one side diuretics and the other side an SGLT2 inhibitor, there's some proportion of the interstitial fluid reduction which was different with context to SGLT2 inhibitors as compared to diuretics. So the mechanism of action just simply cannot be as an expensive diuretic, number one. Number two, there's far more to the mechanism. Everybody is still trying to understand it. The closest that it has come to what has appealed me, at least through the reading of some of the reviews, is that its action via erythropoietin, increasing the red cell mass, and if we understand this, perhaps of leading on to better oxygen carrying capacity, you save most of the other organs. So that's what I feel as. So the action is just simply not because of diuresis.
Your comment, sir.
Basically, diuretics and SGLT2 inhibitors, as you rightly said, SGLT2 inhibitors are drugs which impact the metabolism also. Diuretics are drugs which just lead to increased diuresis, they just impact the electrolytes. There is no other metabolism which they are going to impact. SGLT2 inhibitors have a generalized action over the body. Diuretics have a localized action in the kidney. And SGLT2 inhibitors per se, what you realize is that they produce metabolic effects. How they produce metabolic effects is by increasing the urinary excretion of sodium and fluids, as a result of which you are getting beneficial effects in heart failure. So what was secondary? The beneficial effects at the primary, they are causing loss of glucose, loss of sodium. They decrease the deposition of sodium in the body also, as he said, interstitial fluid changes. And erythropoietin increases, they have realized that the stiffness in the skin as well as in the vessel wall also decreases. So diuretics cannot be compared with SGLT2 inhibitors. SGLT2 inhibitors are metabolic agents with diuretic effect.
Sir, my next question is, you said they also cause sodium excretion. Is there a genuine fear of hyponatremia?
There is a genuine fear of hyponatremia. You are giving diuretic classics or any thiazide diuretic to your patient and you add a SGLT2 inhibitor. We as cardiologists are more focused on potassium. We forget about the sodium levels. So we have to be very sure that the sodium levels are not low. What happens is that whenever you start SGLT2 inhibitors or ARNI for that matter, any drug which leads to increased diuresis, you have to decrease the diuresis. Otherwise you won't be able to upgrade the drug dosage in your patients.
Sir, my next question is, which we often discuss, and Dr. Mangla sir once asked me, sir is an eminent pulmonologist, but more importantly, I always consider him to be a holistic physician. You admit a case for some complication in an ICU, and this patient has a blood sugar of 500, 550. Is SGLT2 inhibition a choice in this patient, in a critically admitted patient? Your viewpoint, Dr. Monashis.
So the beauty of the medication is that all the beautiful data. So if you really need the benefit of this medication, do not ever start it in an ICU setting. And we know about the so-called concept of euglycemic ketoacidosis. The precipitation is sepsis, most of the ICU setting. The precipitation is also related to this hypocaloric intake, A lot of them just not on those kind of a typical calorie intake. So most of these two contributing factors which can actually tilt towards this ketoacidosis and therefore should not be used. This is just like a jewel in the jewel box. Please open it after the patient has come out of the ICU.
No comment, sir. Dr. Samir.
So I would not like to start any such drug which causes so much of imbalance in an ICU setting. So I usually say that we should have a mental makeup what we want to put our patient on. Once your patient is stabilized, shifted from an ICU to a lower HDU, or your patient is discharged, you know everything is stable, then you start giving these drugs. Whether this SGLT2, whether ANI, anything. But patient should be stable.
Sir, another question which me and Dr. Mangla sir often discuss is a patient stable on SGLT2 inhibition and let's say a combination of metformin and a sulfonylurea due for surgery the next day, but stable, blood sugar is fine. Should we continue with SGLT2 inhibition in this patient or we should withdraw this?
So the best is please withdraw, and even some of the standard, if not the word guidelines, but a typical consensus is just to be stopped 48 hours before any kind of a surgery. And even if you have forgotten to stop it 48 hours before, stop it whenever is the next nearest possibility. If the sugars are still alright, the so-called lure and lalach is let the sugar be continued to be in the normal range through the hospital stay. But we have also alternatives like insulin. So it should without any doubt be stopped. If possible 48 hours before any kind of an intervention.
Sir, my last question, Dr. Samir. If we have a case of diabetes at the age of 32 years, type 2 diabetes coming to me, should I start SGLT2 inhibitor right on day 1 along with metformin to this patient to achieve the best cardiovascular outcomes? Because the trials have shown that irrespective of the HbA1c reductions, the results are wonderful as far as CVOTs are concerned. Sir, please, the message.
So that goes, I think the question is for patients who don't have any atherosclerotic cardiovascular disease, who have diabetes, I want to start a drug. So should I choose SGLT2 inhibitors or should I choose metformin? Because SGLT2 inhibitors are shown to have cardiovascular benefits. But you have to remember, as I rightly said before also, there are very specific inclusion criteria in drugs. What has been documented is patients who have congestive heart failure, patients who have LV dysfunction, they benefit from SGLT2 inhibitors. Still, I think, Dr. Monashis, there is time to come when you have a normal LV function and it should be started in these patients. You will not be starting it for cardiovascular benefit. I think you will be starting it for sugar control.
No, my focus is simply CVOTs. I am not worried about HbA1c here.
So then I'll tell my patient to start exercising, take dietary control. I'll not be very aggressive in starting him on SGLT2 in the first go.
So you have the same viewpoint, sir?
Yeah, but as a step further only because it's a glucose-centric oriented question. So therefore, look at the HbA1c. If the HbA1c is roughly around 9%, you would need something 40, certainly beyond metformin. If the HbA1c is classically at around 7.1%, with, if I may add on, a family history of a premature coronary artery disease, which is a kind of a 1 minute of a question answer session, can certainly think about it after some discussion. But by and large, I think we should fundamentally stick to our basics. Start with lifestyle intervention, followed by metformin or with metformin together. Wait for around 3 months. Yeah, again, but initially it is still a kind of metformin with a lifestyle intervention. Give it around 3 months of frame so that becomes a motivational point for the patient. Why so? Because the minimum medications or no medication gives the motivation that lifestyle is important. That's the art. And the moment it fails, then of course you have all the variety of choices, including of SGLT2.
Thank you very much, Dr. Samir. Thank you very much, Dr. Monashis. Dr. Samir is a wonderful electrophysiologist. He is an excellent intervention cardiologist. Presently at BLK Max, Dr. Monashis Sahu has his own practice in CR Park, and Dr. HP Singh has a question, and he will not stop whatever you do. He has to ask that question. Please, sir, go ahead and ask the question, sir.
सर इन हार्ट फेलियर आप कहते हैं कि पानी कम पियो और SGLT2 डाल देते हैं, फिर कहता है पानी ज़्यादा पियो। What is your opinion? My first question.
Very simple. First question.
Well, ऐसे नहीं बोलते हैं सर। पेशेंट आता है।
सर हाँ तो यही आता है कि whenever you start SGLT inhibitor, you should ask the patient to take more water.
See, the problem is that.
See the other side of the heart failure.
So I'll tell you.
You say something else.
You have to look at the ejection fraction of the patient. If my patient is having an ejection fraction of 20-25%.
जवाब तो सुनिए
Sir,
सर।
if my patient is having an ejection fraction of 20-25%, I know that I have to give him a fluid challenge of around 1.2 to 1.5 liters. In this heat, I can increase it to 1.5 to 1.8 liters. My aim is to keep a negative balance of around 500. You have to educate your patient that you should just keep a gross watch about your urine output and your fluid intake, and your urine output should be slightly more than your intake. And the second thing which I tell my patients is that if you start having cough on lying down, if you start having some swelling in your feet, that means you are going in fluid overload. You should either increase your diuretics or you should slightly decrease your fluid intake. So these are the practical things. It's not that we tell कि हाँ LVF है तो fluid कम लेना है, SGLT2 दिया तो fluid बढ़ा देना. The practical thing is the input and the output. The intake should be slightly less than the outtake.
Keep your patient in a negative balance of 500 ml. Dr. SP Singh sir.
नहीं सेकंड बात
ना सर हो गया ना सर।
अभी सेकंड क्वेश्चन
पूछो ना सर, पूछो।
सर माय सेकंड क्वेश्चन इज इन योर प्रीवियस स्लाइड सर की एम्पा प्लस लीना यू हैव मेंशनड FDC व्हाटएवर इट मे बी
सर लीना ही लेना।
मेरा क्वेश्चन ये है सर कि लीना इज अ रीनल प्रोटेक्टिव सब्सटेंस and your EMPA is heart protective.
Sir, EMPA is also kidney protective. EMPA kidney.
Yes, 100%.
And there is lot of trial. There is lot of trial.
आपसे नहीं पूछ रहा हूँ।
पूछो।
My question is, I replace the EMPA with the SEMA. What is your opinion? Yes. If I replace the LINA with the SEMA, what is your opinion?
Or you mean oral semaglutide?
Yes.
Oral semaglutide.
Semaglutide. 3 milligram, 7 milligram, and 14 milligram. Whatever suits with the patient. What is your opinion?
Wonderful.
No, so that's a very important question as well. So the combination EMPA plus Lina में sir, EMPA plus Lina में if something can be replaced, so that is Lina that needs to be replaced with the oral semaglutide. And the EMPA should never be replaced with the oral semaglutide. Never ever. Because the mechanism of action is completely different.
But
So therefore, if you have got an opportunity to replace something, it is the linagliptin which slightly increases the GLP-1 levels. That should be taken out and bring that oral semaglutide, which is nothing but a GLP-1 agonist. So that is the answer for this question. But yes, as in science, we can say anything, but as for the art of medicine, of course it is to do with the discussion of the patient. Anything is fine with EMPA plus semaglutide instead of EMPA plus Lina. Thank you so much.
I think we had a wonderful discussion, friends. Let's give a big hand to Dr. Manish, Dr. Monashis, and Dr. Samir Mehrotra. My duty was to introduce Dr. Samir Mehrotra to the gathering and was to introduce a rejuvenated Dr. Monashis Sahu, who is back to life, back to work, with the blessings of God and with the blessings of his family. We love you, sir.
Thank you so much.
Wish you a long life, sir.
It has been a very emotional journey last year, and
Yes.
thank you so much for taking so many of us.
Absolutely, sir. And I would like Dr. Manish Gupta to summarize this CMP for us.
So thank you sir for the opportunity. I think we learned a lot tonight from the SGLT2, from the on a lighter vein. I would just like to end just one thing about the history of me and Dr. Chauhan were discussing when we went off, and I was reading Wikipedia. The SGLT2 receptors are there in the gut. right? So the initial glucose failed because it caused massive problems in the gut as well. So maybe there is a role, if you can selectively get those, is this the new agaribose, oglibose role, right? It just, induces the mind, but it leaves the food for thought. But again, some of the CME, excellent talk. We have a drug, we have a molecule which we should use, the FDC, and we have increasing evidence for heart failure, for CKD. I think hats off. Thanks everyone.